Okay, let's go ahead and read this question. Let me know what you think about it.
So I'm thinking he probably has Norwalk virus
Okay, and why is that?
because it's the other ones like our Yersinia enterocolitica. That's like from dogs and prairie dogs, all that stuff. So we're gonna eliminate that. Um, Shigella, it's not bloody.
Hmm.
Rotavirus is usually like in daycares.
Yep, exactly. Daycares in unvaccinated children.
Mm-hmm. Salmonella, I just don't think it fits.
Okay.
Um, I only what I was kind of thinking was E maybe, like because it can present with watery diarrhea, but I don't think that either for some reason.
Okay. So it actually is E.
Oh my gosh, it is. I was thinking it might have been E. It was like hard to tell because it's like they're not really giving you much here.
Yeah. So which parts of this question lean more towards E and which parts lean more towards G?
So I guess the E tox is like more because he traveled.
Yeah, recent travel to Middle East.
Um, I think like the watery diarrhea
That can
leans
actually be
towards Norwalk.
actually both of them have watery, non-bloody diarrhea.
Mm-hmm.
Um, and they're both typically foul smelling.
Mm-hmm.
Let's see what else. Abdominal bloating, increased flatulence, diarrhea 6 to 12 times daily. Um, those actually are both. It can be either one. But for these diarrhea questions, the history is very important. So it's really just this recent travel to Middle East.
Really? Okay.
Um, and E-Tech is found there. Um,
Mm.
yeah. What would be the clinical history for Norwalk virus?
Shellfish,
Yeah, shellfish or like what kind of travel?
endemic.
Like what kind of vacations do these patients
Oh,
take?
cruise ships.
Yep, cruise ships. It can also be in like military, so like close contacts, and also like schools.
Mm-hmm.
And another thing that these patients present with is not just nausea and diarrhea, but also a lot of vomiting as well.
Mm-hmm.
Um, yeah, but it's just that clinical history pointing towards E-Tech. Okay. What's another name for E-Tech?
Can you give me a hint?
It starts with an M. It's like a South American name.
I have no idea.
Revenge. It's known as Montezuma's Revenge because a lot of these are from like a lot of E-Tech is from South America.
Mm-hmm.
Um, and this is actually the most common cause of travelers' diarrhea. It's very, very common.
Mm.
Um, any idea how we diagnose this?
Um,
It's
do you
bas-
do a stool OMP?
uh, not O&P, but stool culture
Mm-hmm.
microscopy. Basically, how we diagnose most causes of infectious diarrhea outside of the stool O&P for like parasitic. And then treatment, do we give antibiotics?
No.
No, it's generally supportive and
Mm-hmm.
generally it's self-limiting. But if
Mm.
it's severe, then we give antibiotics.
Okay.
Okay. So how do you typically approach these questions? What's the first thing that you look for in diarrhea?
Um, like infectious versus non-infectious, or
Um,
like inflammatory versus
yeah,
non-inflammatory, like
inflammatory
bloody
versus
versus
non.
non-blood. Yeah.
Yeah. Which one of these are bloody?
Shigella.
Yep, Shigella.
Anti histolytica.
Yep. So bloody equals D, I. Any other ones?
Mm,
There's actually five.
Campylobacter.
Yep. Campylobacter typically starts off non-bloody, but then it becomes
Bloody, yeah.
later, and it is very foul smelling.
Salmonella.
Salmonella, um, specifically the Salmonella enteritidis,
Hmm.
whereas a Salmonella typhi, those patients have rose spots on the abdomen
And then
and high fever. Um, while we're talking about Salmonella typhi, what's unique about their heart rate?
Salmonella typhi.
Yeah.
Unsure.
So these patients have high fever. And then what typically happens when we have high fever?
High heart rate.
Yeah, high heart rate. However, um, these patients have relative bradycardia. Um, so Salmonella typhi is non-bloody, rose spots on the abdomen, high fever, but relative bradycardia. Um, and this relative bradycardia is really interesting because typically for every degree Celsius over 38, so for every 1 degree Celsius, we get plus 10 heart rate on average. So a patient with a 40 degree Celsius fever, we'd expect their heart rate to be closer to 100. But these patients will have like 70. What's another bug that might do the same thing? These patients also have hyponatremia.
Legionnaires.
Yep, Legionnaire's disease. Excellent.
Hmm. That's interesting.
Also seen in Legionnaire or Legionella. Legionella. The reason why is because these bugs are intracellular. There's other bugs that are intracellular that don't do this, but both of these are intracellular. And it's thought that by being intracellular, they bypass the inflammatory response that stimulates the heart. Okay, excellent. So
So explain the 38 degrees Celsius plus 1 degree Celsius thing again.
yeah, so 38 degrees Celsius is exactly the cutoff for fever.
Hmm.
It's 100 and 100.4. And typically for every degree Celsius above that, we have an increase in our baseline heart rate of 10.
Hmm.
So my baseline heart rate is about 60. If I had a 102-degree fever, I'd expect my heart rate to go up by 10. So it'd be 70. If I have a
Hmm.
really, really bad fever, like 40 degrees Celsius, which is about like 104 degrees, I'd expect my heart rate to be 80. If I had Salmonella typhi, maybe I had a recent visit to China or Thailand, and I and the servers didn't wash their hands or whatever, then my heart rate would still be around 60 to 70, even though I have really high fever.
It makes sense.
Okay. Yeah. So
So it's just these are the two exceptions.
yeah.
Okay.
So for example, you would have like 103-degree fever, but the pulse would be like 70 or 75. Okay. Any idea what the last bug here that can have bloody diarrhea? This generally presents in toddlers.
So it's the rotavirus?
Not the rotavirus.
Oh, Yersinia.
Yersinia. Excellent. So
I just remember the baby, the sketchy.
yeah, he's sitting on
The
a
thing.
red stool.
Hmm.
So yeah, exposure to like puppies, undercooked meats, and contaminated milk. Okay. What's the like clinical history for Clostridium difficile?
Antibiotic use, hospitalization.
And chronic something use.
PPIs?
Yep, PPIs. Excellent. Um, C, Entamoeba coli. This is just I've never heard of this, honestly. So you can just cross it out. Anything that you never hear of, you can just cross out. This is actually a commensal organism. Um, and we just said the H was unvaccinated children, common in daycare. Um, and these patients will also have nausea, vomiting, and diarrhea. So rotavirus. Um, any questions about any of that?
Mm-mm.
Okay, so when do we not want to use loperamide for diarrhea? Notice that this patient's on loperamide therapy.
For C. diff?
For what?
C. diff?
Um, it's not that specific, but yeah, for C. diff, we generally don't want to. Um,
For UC?
it's generally for diarrhea that is bloody or febrile.
Mm. Is it because it could lead to like toxic megacolon?
Yeah, it can lead to toxic megacolon. It can also just lead to like impaired expulsion of the bacteria, right? Because we poop to get that bacteria out of our body. If we are trying to retain that poop, then that bacteria can just continue to invade. But specifically, we don't want to use it for bloody or febrile diarrhea. Basically, diarrhea that is strongly infectious. Just use caution in general for all bacterial diarrheas. Okay. Um, so we said E-tech was watery diarrhea. What's another kind of E. coli that is bloody diarrhea?
Yeah.
EHEC. Awesome. Um, so that what kind of symptom does that cause?
It's like Shigella.
It has Shiga like toxin,
Mm.
but it causes what kind of disease?
ARDS.
It does not cause ARDS.
Um, what does it cause? Can you give me a hint?
It causes a condition with a triad of symptoms, including hemolytic anemia, AKI, and thrombocytopenia.
I have no idea.
Okay, so this is hemolytic uremic syndrome.
Oh my gosh, yes, I do know.
I
Okay.
knew you were gonna say that. Yeah, so triad of symptoms is what kind of anemia do they have? It's
Mm, I'm not sure.
going to be hemolytic anemia. Specifically, is it microangiopathic or macroangiopathic?
Micro.
Yep, microangiopathic. What's an example of macro?
Um, Black Fan Diamond Van syndrome
Um, maybe. I'm not sure if those are. The
I
one that I was,
forget. Macro was like hardly tested.
yeah, it's hardly tested, but like aortic stenosis is one of those.
Oh yes,
Aortic
because the
stenosis.
shearing.
Yep. Yeah. So in microangiopathic, what's the pathophysiology? So this Shiga-like toxin causes small clots to form.
Like the fibrin clots.
Yep. Small clots form which lyse red blood cells, causing what kind of cells appear on blood smear?
Cystocytes.
Histiocytes, awesome. Because this is a hemolytic anemia, what's going to be the LDH level and the haptoglobin level?
LDH level is low, haptoglobin's high, right?
It's going to be the opposite. So remember the
So
LDH.
LDH is high. They test that a lot.
Yeah, LDH is an intracellular enzyme.
Yeah.
Um, and then haptoglobin. What does haptoglobin do again?
Mhm. Hmm?
What does haptoglobin do again?
Isn't it like a carrier?
Oh, I see that my um the internet is freezing a little bit. Let me go ahead and try opening my door and see if that helps.
Okay.
Okay, I think it's better now. Okay, so haptoglobin, it's a carrier for what?
Hemoglobin?
Yep, hemoglobin. And so
Oh gosh. You're testing the nitty-gritty step one stuff. Like, oh my
yeah.
gosh. This is like, but this is so good because I don't know if I push myself this on my own. Okay.
Yeah, so haptoglobin binds to hemoglobin. And so when there's lysis of red blood cells, it releases a lot of hemoglobin. These carrier proteins, haptoglobin, then go and bind it. Once it's bound, it's not detected in the serum, and so it's low.
Oh, because the red blood cells are lysing, so the hemoglobin is like being released and then it's binding
Yep.
to the haptoglobin.
Correct.
Oh, okay.
Okay. Do we give antibiotics for EHEC?
Yes.
We actually do not.
What? Oh my gosh. Okay.
The reason why is because when we kill bacteria with antibiotics, it releases the toxin and therefore worsens the HUS. It can worsen or trigger the HUS. And there's actually another cause of hemolytic uremic syndrome. What other bug can cause hemolytic syndrome?
Together.
Yep. So less commonly secondary to Shigella.
Mhm.
Do we give antibiotics for Shigella?
Yes.
Yes. I don't know why. I don't know why.
What antibiotic do we give again?
I actually don't know. It's a gram-negative bug, so maybe a ceftriaxone or a metronidazole, given that it's a
Ooh,
GI bug.
yeah.
Yeah, I would guess metronidazole or like a ceftriaxone, or maybe even just like a Zosyn, piperacillin tazobactam, but I'm just guessing. Okay, and so HUS is very similar to another condition. HUS has AKI, thrombocytopenia, and anemia. What if we replace the AKI with neurologic symptoms?
Oh, I know this. TTP.
Yep,
I've gotten this wrong so many times that I think it's ingrained.
awesome. Yep. And yeah, thrombotic, thrombocytopenic purpura. Um, what kind of anemia does this have?
Mm. Um, it's macro, right?
It's also micro. Trick question. So these are both microangiopathic
Get the
hemolytic
deep
anemia.
cuts here. Okay.
Okay, and then what's the mnemonic for these symptoms? There's an inappropriate mnemonic that people use.
Fat RN.
Yeah, the RN. Um,
Oh, it's not that inappropriate.
okay, yeah.
Fever, anemia, renal, thrombocytopenia,
Is
neurologic.
is fever common?
Not really.
No, it's only present in 20% of patients.
Yeah. And then like I don't know, sometimes the way they present it is like the neurological symptoms are pretty subtle.
Interesting.
I feel like because they'll just be like, oh, the person was kind of confused. Like sometimes it's hard to know like what does that even mean? I don't know for me.
Right. From my perspective, confusion is kind of severe. Like,
Confusion severe.
yeah, like I would think if the patient was confused, like
Okay. So
it's
like when you
really,
think confusion, think severe.
what was that?
Oh, so you see confusion, you think severe.
Yeah, I associate confusion as pretty severe. Most people aren't confused on a daily basis.
That's true. That's true.
Oh yeah, but they emphasize that renal symptoms are more in HUS and
Mhm.
neurologic symptoms are more in TTP.
Okay.
And yeah, fever is only 20% patients. And then what's like any idea what the pathophys of TTP is? It's low blank levels.
Low what levels? Wait,
Some kind of
low.
enzyme.
Oh, it's the Adams TS13.
Yep.
Okay. That's
And
what I thought it was, but I wasn't like, I wish, okay. I thought that like when you were saying, yeah.
yeah. And it's typically due to autoantibodies against this
Hmm.
or some
And
kind of
that's why you have to do like, wait, can I like, I want to talk through this. So that's why you have to do like, you don't do, ugh, gosh, what's the word? You do like, you don't do platelet transfusion, you do something else.
correct.
Um, not like,
This can be life-threatening, and so we don't want to wait for the platelet transfusion. Um,
what is it?
it's going to be plasma exchange.
Yeah, that's what I meant. Because you want it to stop. You want the thing to stop.
Yep. Yep.
Mm.
Um, what's another name for plasma exchange? I used to think that these two things were different, but they're actually the same.
Can you give me like a multiple choice that I could get it? I just cannot think of this.
I there's it's just one specific name.
What's it start with?
Plasma.
Oh, it starts with plasma.
It's just plasmapheresis.
Oh yeah, that's what I see. I knew that's what it. Oh God, I just yeah.
Um, yeah, and a lot of the plasmapheresis conditions, they're just removing the autoantibodies. So autoantibodies against atom TS13 equals low atom TS13. So basically, this normally cleaves von Willebrand's factor,
Hmm.
but because it doesn't, we have large von Willebrand factor multimers, and these can aberrantly activate. Aberrant activation equals platelet activation, which
Yeah.
forms clots. So the the root cause is just clots in both of them. HUS is just small clots forming from this toxin. Here we form clots because of aberrant large von Willebrand's factor multimers.
Hmm.
And yeah, we want to get rid of the antibodies with plasmapheresis. What other things are treated with plasmapheresis? This is a tangent.
Can you like give me a hint?
Yeah. And plasmapheresis is also known as flex, which is plasma exchange. Um, so I'll list off a bunch of symptoms. Um, lumbar puncture shows elevated protein, but no white count. After a Campylobacter jejuni infection,
Mm.
these patients have ascending paralysis, but it's not because of a tick bite. Tick bites can also cause ascending paralysis.
It's not like Miller-Fisher syndrome.
Miller-Fisher syndrome is a specific kind of this. And
Albumin
Miller-Fisher syndrome,
cytologic.
Yeah, I'm describing albuminocytologic dissociation.
Oh,
But what is that found in?
I'm gonna call it Guillain-Barré.
Yep, Guillain-Barré.
Oh, okay.
Yeah, it's Guillain-Barré syndrome. Know that it has albuminocytologic dissociation with ascending paralysis. And then know that Miller-Fisher syndrome is also treated with plasmapheresis. What's Miller-Fisher syndrome?
It's like antibodies at the G1QB.
I didn't even know that. Um,
Like it's very similar, except that it has like
there's like additional symptoms.
ophthalmologic.
Yeah, eye problems, eye problems.
Oh, yeah, yeah. It's like it's such. I've gotten that question wrong 100 times as well too, so I like made sure.
Yeah,
Yeah.
it's GBS with ophthalmoplegia, so like
Yeah.
the eye paralysis.
Hmm.
Um, so it's not necessarily ascending paralysis. It starts in the eyes, and then these patients, I think of it as um, fish don't have good eyesight. It's really bad. It's a really bad mnemonic, but fish don't have good eyesight, and they also can't walk properly, so they have ataxia and areflexia. Terrible mnemonic. Does not make any sense. Okay, so eye paralysis and just ataxia. All right. What condition is characterized by excess IgM?
Waldenstrom,
Yeah.
microglobulinemia.
Um, from step one, we know that IgM in the blood, it's found in pentamers.
Yes,
And because of that, what kind of syndrome does this cause? Hyper blank syndrome,
hyperviscosity,
viscosity. And so these patients, they also get
blurry vision,
problems, blurry vision, and they get,
the M spike.
yeah, they get M spike, they get neurologic and eye problems. And once again, we're removing antibodies with plasmapheresis. All right, what about, oh, we said TTP. What about a patient that presents with ophthalmoplegia that gets worse in the evening? Um, and now they're having difficulty breathing. This patient is on pyridostigmine.
Myasthenia gravis.
Yeah. And since they're having difficulty breathing, what is that? They have a restrictive lung disease. They can't inspire.
Diaphragmatic paralysis.
Myasthenic crisis.
Christ. Oh gosh.
Myasthenic crisis.
Mhm.
Um, okay. And then what about a patient? Also, for myasthenia gravis, what temperature do their symptoms improve at? Warm or cold?
Cold.
Cold. Yeah. We had a patient with myasthenic crisis. Their room was freezing. And for some reason, our attending loved to just spend forever in that room. Okay.
Wait, so why do you like to spend forever?
I don't know. He was just talking to the patient for a very long time.
Oh, he liked to. Oh, the room would be really cold.
Yeah, the room was really cold and we were just all freezing.
Mm.
Okay. And then what condition presents with hemoptysis and hematemesis? Specifically in like a 25-year-old male. This is a type 4 collagen problem.
Outward.
Uh, the other type 4 collagen problem,
What's the letter?
uh, G.
Oh, that's what I also thought. Granulomatitis with
No,
poly.
not that one.
Huh?
Granule, that's a good thought.
No?
Hemoptysis is present in that. Um, and
G?
actually, wait, hemoptysis. Oh, sorry, I didn't mean to say hemoptysis. Hematuria.
Oh, okay. Good pastures.
Yeah, sorry.
Sorry. That's why I was getting a little confused. I was like, oh.
Yeah, good pasture, sorry. This
Mhm.
generally happens in like males in their 20s. Um, it's from autoantibodies against what membrane?
Basement.
Yep, basement membrane. It's a type 4 collagen problem. Um, any idea which syndromes here we also treat with IVIG?
Um,
There's,
it's Guillain-Barré,
yep, Guillain-Barré.
Miller-Fisher,
Yeah,
myasthenia crisis.
yep, excellent.
Yeah, it's very expensive, IVIG.
Really? I didn't know that.
Yeah, like I don't know. We had like some patient who like wanted to walk out. I forget what he had, but he like needed IVIG, and like my attending was really mad. She's like, now if we ever get some kid with like Kawasaki's disease, like they're not gonna be able to get it because this guy like he's like not even taking like you treat Kawasaki's with IVIG too, right?
Yeah, I was actually gonna ask you that.
Yeah, because she went to this whole speech about like, oh, this guy's like, just like I don't know, ungrateful that we're getting because it's like $50,000, and she's like, he's so ungrateful, and like, if a sick kid comes in, we're not gonna have it now, or whatever she was
Oh,
saying.
so he was given IVIG, but he just left?
Yeah, and like he didn't like he was like, oh, I'll come back. Like I don't know if he was a drug addict, but it just seems like he just like as I guess there's a certain protocol when you give it, and he just like wasn't trying to follow it, and she was just like,
Mhm.
oh, like we shouldn't even be giving it to this
Dang.
guy. Yeah, so it's
No.
very expensive. I've heard. I didn't know that until recently.
Yeah. I feel like everything in medicine is super expensive. Like
Very.
TPA is supposedly very expensive, and so we can't include it in code cards, even though it's like pretty standard in a lot of
It's
code.
necessary.
Yeah.
Wait, TP is expensive? I thought it was so cheap because you have to give that to like everyone with that has a stroke.
Um, I think it's expensive enough to where they can't include it in all the code cards.
Ah,
But yeah, apparently, like there's a uh, expiration date, like early expiration date. Okay, what else do we give for myasthenic crisis?
mm, I'm not sure. Get parastigmine.
Uh, we do give that pyridostigmine for myasthenia gravis, but when they're in crisis, we want to stop a lot of autoimmune conditions in the acute phase, we use steroids.
That's like multiple sclerosis. You give steroids, and then for long term management, you're gonna do interferon beta.
Yep, interferon beta or glitaramer or natalizumab.
Mm. Adalimumab is just Humira.
Humira. Interesting.
Yeah, we give that in derm.
Oh, interesting. What for?
You could do it for hidradenitis suppurativa.
Okay, interesting. I didn't know. I did not know that.
Yeah, I mean, you're probably never gonna see any of this because you're doing radiology.
Yeah,
You're
that's true. I have all of this useful knowledge, useless knowledge in my brain. Let's see. What other condition is treated with IVIG and steroids and also has thrombocytopenia?
Is it an older or younger person?
It can be in either. Um, Thrombocytopenia.
Oh, is it a skin condition?
They can have bleeding, but it's not necessarily a skin condition. These patients generally have like lupus or some kind of viral infection like hepatitis C or HIV.
Oh, I know what you're talking about. This is the kidney thing. This is the one that's bad. This is the one that's I know it if I see it. Um, it's like when they yeah, it's the really bad kidney one, focal segmental.
That's actually a very interesting thought. They generally won't have thrombocytopenia in
Oh,
focal segmental. Um, but yes, they do have HIV. I I think lupus is membranous nephropathy,
yeah.
and hepatitis C, I think that's also that's focal segmental. Actually, no, it's membranous nephropathy as well.
Yeah, yeah, it's both. Yeah.
Yeah. Membranous nephropathy is lupus and hep C. HIV is focal segmental. Um, but yeah, these patients get auto antibodies against platelets. The name is very similar to TTP, and I used to always confuse the two.
ITP.
Yep, ITP.
Oh. But it could also just be like no cause, like
Yeah,
random.
probably the most common cause is idiopathic. Um, and yeah, high yield to know the treatment for this is steroids, IVIG, um, and you can give like anti-D antibodies. Um, and then yeah, TTP, it's plasma exchange. Um, we also give steroids and rituximab. So
Makes
they overlap in steroids and they sound very similar, and they both have thrombocytopenia. Do you remember how the treatment for ITP is different in children versus adults?
in children, you're gonna do a splenectomy?
No. If if refractory to all of these treatments, then we can give splenectomy.
Well, you do platelet transfusion, depending on how low it is, if it's less than like 50,000. And then I think if it's less than 8,000 in children.
Um, so generally in children, it's all symptom based.
Okay.
We treat if symptomatic, so um, not including what kind of bleed, mucosal bleeding,
Oh, okay.
mucosal bleeding. So if they have just like a bloody nose, we don't necessarily have to treat. But if they have like a bloody joint, that's more concerning. And then in adults, we also treat if symptomatic or if platelet count is less than how much?
50,000.
It's going to be generally 30,000. 30,000.
Okay. I do remember there was this question on my IM shelf, like the person had no bleeding, but their platelet count was like 8,000. Would you give them platelet transfusion then?
Um, I think so, but I would have to double check.
Okay.
Mm, yeah. And I don't see anything about platelet transfusion on AMBOSS either.
Okay.
So I don't know. Um, and the splenectomy is if it's refractory greater than 12 months. Okay. Any questions about any of this?
Mm-mm.
Okay. And then just real quick, besides GBS and myasthenic crisis, um, ITP. So the list for IVIG is GBS, myasthenic crisis, ITP, and Kawasaki's.
Makes sense.
Okay.
E.
Not going to be E.
Wait. So she has. It's not A. Is it A? I thought A was like that's like. I mean, I guess it could be A.
Yep, it's A.
Oh my gosh, I don't know why I was thinking like. Sorry, excuse me. So like, I don't know what I was thinking. I don't know because it does move into because this is like a DKA, right?
Yeah, this is DK. So there is there is movement of potassium into
But that's
cell.
not the reason why she has her acidosis.
Um, well, there is a channel. Were you thinking about the H plus K plus channel?
No, I don't know. I feel like my thinking was like thinking type 1 versus type 2. I don't
Okay.
know where my thinking was going here.
Okay. Real quick, let's cover this channel, H plus K plus channel. Um, generally, when we have acidosis, how does that affect potassium?
Increases.
Yep. Um, and then if we have alkalosis, we have hypokalemia. Basically, when H plus goes into when
Mhm.
H plus goes into cells, it kicks out potassium. Um, okay. So what's the diagnosis here?
Diabetic ketoacidosis.
Awesome. Is that with type 1 or type 2 diabetes?
Type 2.
Type 1.
Oh, it's type 1. Oh, because, oh, all right. And then you get, sorry, I think I'm just a little tired. So type
Yeah,
2, you get
it's so late.
yeah, no. Sorry. So the type 2, you get hyperosmolar. Sorry. My brain, like, I'm just like, feel like I'm overthinking without thinking. Okay.
Yeah. And I'm sorry for
No. You're fine. I usually stay up late. It's just like
okay.
but
Yeah.
okay, this makes sense.
Okay. Yeah, so DKA is type 1 because there's no insulin at all.
Hmm.
Um, is this so usual presentation? Is it generally a young adult or older adult?
It's usually younger adult.
Younger adult.
And
Excellent.
then if it was like HHS, or whatever, hyperosmolar or whatever, or it's it would be like the glucose would be like in the thousands.
hmm Is this
It's
type
like
1 or type
crazy
2?
high. That's type 2.
Your diabetes, so usual presentation. What's the age group?
Older adults, like elderly.
Adults. Yep, elderly. Um, and you said glucose was in thousands.
Hmm.
Typically, what's the threshold? Approximately.
Um, What do you mean?
Like HHS has a higher glucose, typically
Greater
great.
than 1,000?
It's certainly like greater than 600,
Okay.
and DK is usually glucose is typically less than 600. But I want to
Oh,
emphasize that this is not like reliable, not
yeah.
reliable because as you can see, glucose here is 783, so it's not reliable. Both of them can have very high glucose. Generally, though, DKA presents earlier, and that's because they have zero insulin whatsoever, and so their cells are very, very starved from an early onset. So generally, the patient will present to the hospital before their glucose gets to 783. Generally, it'll be like 200 or 300 or sometimes 400. Um, why is this patient tachypnic?
Because they're trying to like compensate
Or,
like the metabolic acidosis. So they're
yep,
breathing a lot, trying to get
yeah.
rid of
And what kind of acidosis is this?
metabolic.
Is it high anion gap or normal anion gap?
Mm. Hi.
Yep, high anion gap. I remember mud piles.
Hmm.
Do you use mud piles or Goldmark?
I use my pile still. I
Okay.
can't remember golden mark. It's just too long.
Yeah. Okay, so it's the D in mud piles. Um, and so they're so breathing off CO2 to compensate. Um, speaking of which, um, how confident do you feel on acid base like
I feel
compensate?
pretty confident. I think sometimes there is like ones that are weird, like with the mixed ones. But like
Okay.
I do learn it from dirty. I feel like I learned it from dirty medicine during like first 2 years of medicine, where it's like if it's like if like you have a respiratory acidosis, it's like the CO2 is high. If it's not high, that means it's metabolic. Like I learned like
Okay.
the CO. You know what
Are
I'm
you okay
saying?
doing a quick practice question?
Mhm.
Okay. Let's say pH is 7.28, PaCO2 is 37, and bicarb is 18. What's the abnormality? And this could be this patient here, 18.
Oh, this is like mixed, right?
How can you tell if it's mixed or not?
Because like they both go down.
So actually, in all compensated acid-base anomalies, the PCO2 and bicarb are going to move in the same direction.
So is this yeah, so this is like a mix. So it's like compensating. So it's so the
Oh, is it?
primary abnormality, but we're not able to tell the prime I guess the primary abnormality is it a metabolic acidosis? I mean alcohol acidosis?
Well, we can tell because first off, what's the normal pH?
7.3. 7.4.
7.4 typically.
Mm.
7.4. Remember the rule of four, 7.4, PCO2,
45
or
or
40
40,
generally, and
24,
bicarb
24.
24. Yep. Remember the rule of fours, right? They all
Mm-hmm.
have four in it. Um, and so they're both going down. Which one is causing the acidosis?
I would assume the HCO3.
The HCO3, right? Because HCO3 is a basic compound.
Mm-hmm.
What is CO2? Is it basic or acidic?
That's it.
Acidic. So if you have less acid, that would actually be causing a alkalosis, not an acidosis.
Mm-hmm.
So we know that this is a primary metabolic acidosis.
Mm-hmm.
Anytime we have a metabolic acidosis, what are the two formulas that we use?
Um, only time we have a primary
Mhm.
winters.
Yep, we do Winters
Do you
anytime.
really need to know those? I don't feel like you do.
Um, I think it is helpful, but I would say for like 50% of the questions you could answer purely based off the clinical history, but I do think it is helpful.
Okay. It's
So
probably
yeah, anytime we have a metabolic acidosis, we want to do two things. We want to calculate the Winter's formula, and we want to um, calculate the anion gap. Um,
anion gap is so easy though. It's just so sodium and then chloride plus HCO3.
yep. So what's the anion gap here?
So the anion gap here is so 99, 117, 22.
22. Awesome. Okay, and then do you remember Winter's formula by any chance?
No.
Okay, so it's
I never memorized that formula through med school. I just looked at it a whole bunch of times. I'm like,
so the expected, it tells us the expected respiratory compensation for metabolic acidosis. So what the PaCO2 should be. And it's
mhm,
going to be 1.5 times PA, or no, 1.5 times bicarb.
mhm.
So all you have to remember is 1.5 and 8. That's basically the gist of it. And then there's a plus or minus 2 range. So if you can remember two numbers, you're basically there. What is that? What's the expected PaCO2?
1.5 times HCO3. What's 1.5 times 18? There.
That's
Is it just 14?
it's 27.
Oh, oh yeah. I really suck when it comes to like the sorry, the decimals.
No worries. So yeah, we just take half of 18,
Oh,
which is
oh,
9,
you're right.
and
Sorry.
100. No worries.
Okay.
27 plus 8.
35.
Yep, so 35. So our range is so plus or minus 2. So our range is 33 to 37. And so it's within this range. PaCO2 is within this range, which means that is it appropriate compensation or inappropriate?
Appropriate.
Yeah, with appropriate respiratory compensation. What if the PaCO2 was above the range? So what if it was 40?
So we would think that it's a mixed.
Yes, what kind of mixed?
So we would think like when we think like a primary, so a primary respiratory acidosis. Well, wait. So you think like mixed metabolic acidosis with respiratory acidosis?
Excellent. Yep.
Okay.
Um, so if we measured this patient's ABG and we found that the PaCO2 was 40, that's a sign that this patient with DKA is now undergoing respiratory failure. So they shouldn't have a respiratory acidosis. If they do, they're undergoing respiratory failure, which actually does happen in DKA patients. Um, and generally, like just the basics, what are the basic causes of a respiratory acidosis versus respiratory alkalosis? Like could you list like two or three causes of each?
Respiratory acidosis. Um, I know
Okay.
respiratory alkalosis is like high altitude sickness.
Yep. Mountain sickness is for sure a respiratory alkalosis. Uh, which one is like hyperventilation and which one is hypoventilation?
Hypoventilation is respiratory acidosis.
Yep. Ventilation, hyperventilation. Um, and so this is things like Mountain sickness. Actually, the you're right. High altitude. Uh, What's that? What's the actual terminology? High altitude. I don't remember.
Uh,
It's high altitude.
yeah, I think it's that altitude.
Okay. High altitude. Things like uh, early asthma exacerbation. Things like pneumonias, typically respiratory alkalosis. Um, Anxiety, anything that causes hyperventilation. Whereas hypoventilation, what are some causes of this?
Mm. Coma,
Say that
um,
again.
like a coma, or
Um,
I'm not saying obesity, hypoventilation
yeah,
syndrome.
excellent. Severe obesity is one. So like something that causes a mechanical restrictive lung disease.
Hmm.
So other things that cause a mechanical restrictive lung disease. So we can have obesity, we can have uh, ankylosing spondylitis,
Yeah.
we can have um, Guillain-Barré syndrome and myasthenic crisis. We can have um, pectus excavatum in Marfan. We can have severe scoliosis. Um, any like what's like an obstructive lung disease that can cause hypoventilation? A lung disease that causes a CO2 retention. Generally, for these patients, if they have an exacerbation, we don't want to raise their O2 saturation too high. We want to keep
Oh,
it around,
COPD.
yep, COPD. We want to keep it around 92% typically. So COPD is CO2 retaining, and so they have a respiratory acidosis. Okay, excellent. Um, what if we have like a patient with recent ingestion and then now their pH is 7.34, PaCO2 is 30, bicarb is 18, and they have complaints of tinnitus.
Aspirin.
Yeah. So what kind of toxicity is aspirin? Like, I mean, what kind of acid base problem?
Oh, do you see?
Oh, Alexia, can you hear me?
Sorry, you cut out a couple times.
Oh, sorry about that. What is what's the acid base anomaly?
Um, at first you get alkalosis, and then you go to acidosis,
Yeah, initial, what kind of acid alkalosis?
respiratory,
Yeah, respiratory. And then late, so greater than 12 hours typically.
metabolic acidosis.
Yeah.
And then sometimes you'll see, like in the middle, you see no abnormality.
Yeah. So it can be very close.
Uh-huh.
Okay. Um, okay. And then yeah, so this patient is breathing fast. Sorry, just going back to the DK. They probably have Kussmaul respirations,
Mhm.
which are like rapid and deep. Do they have elevated ketones? Zero ketones.
Yes.
Yes. What are the other two ketones that are elevated?
Beta-hydroxybutyrate and then like acetoacetate or right?
Yep.
And then beta-hydroxybutyrate is more than acetoacetate. Then a 2-to-1 ratio, right?
The last one is what makes their breath smell fruity.
Acetate.
Yep, acetate or acetone. And then how do we treat DKA?
Um, you give them IV insulin,
What's the first thing we give before insulin?
fluids,
IV fluids. And we give insulin.
plus
What?
potassium.
Yeah, potassium. We want to give potassium at the same time as insulin because insulin can, does it cause hyper or hypokalemia?
Insulin causes hypokalemia.
Insulin causes hypokalemia. Excellent. And that's why it's used in hyperkalemic, um, symptomatic hypercalcemia, symptomatic hyperkalemia. Okay. And then HHS, um, do these patients have a metabolic acidosis?
No.
Yeah, no metabolic acidosis because no ketones. How do we treat this?
Um, don't you give like IV insulin again?
What do we do before the IV insulin?
Fluids.
IV fluids. It's the exact same thing.
Okay.
Okay. Um, and then yeah, aspirin is a high anion gap. Um, what high anion gap metabolic acidosis are you thinking if a patient has eye problems as well? Think mud piles. If they have like,
Glycol?
did did you say methanol?
Oh, I just said ethylene glycol.
Oh, so it's going to be methanol.
Mm.
Um, so methanol and ethylene glycol, they're very similar in that they're both alcohols. Which organ does ethylene glycol affect?
Liver?
It's going to be the kidneys.
Oh,
So they both cause high anion gap metabolic acidosis, and they're both treated with what treatment?
not sure.
So it's a drug that inhibits alcohol dehydrogenase,
Omeprazole.
fomepizole. So remember, methanol affects eyes, affects kidneys. What kind of kidney injury does it cause? Does it cause pre-renal, intrarenal, or post-renal?
Enteral.
Intrarenal. Do you know what the most common cause of intrarenal AKI is? Say that again.
Alcohol?
Not alcohol. It's going to be acute tubular necrosis.
Mm,
So ethylene glycol causes acute tubular necrosis. Um,
muddy gas.
okay. Um, remember that, yeah, these will have muddy brown casts. Um, and what are the causes of acute tubular necrosis again.
Dehydration and antibiotics.
Dehydration. Yep, excellent. Um, Causes number one is ischemia, or number two is nephrotoxicity. I actually made a mnemonic for ATN. I think it's pretty decent. Ale and rum. Ale and rum. They're often combined together in drinks. And yeah, aminoglycosides. Um, what's a heavy metal that can cause ATN? Starts with L.
Lithium.
Lead.
Oh, sorry.
Lithium is actually quite light.
Uh,
Uh,
ethanol. Ethylene.
ethylene glycol. Ethylene glycol. Um, what is given with CT scans?
Contrast.
Radio contrast.
Yeah.
I,
And you
um,
have to avoid contrast in people with issues.
yep. And this is the exact reason because it causes ATN.
But you use for kidney stones, you have to use contrast.
Actually, kidney stones, you don't use contrast
Really?
because the stones look like contrast. They're
Mm.
hyper intense. They're calcified and therefore they light up bright.
For
Yes.
nephrolithiasis, is that's kidney stones, right?
Yes. No contrast with kidney stones, whereas we do use contrast with a similar condition in the kidney that causes an infection, pyelonephritis.
Okay.
Pyelonephritis, we do use contrast.
Mm.
Generally, though, in the hospital, they get contrast anyways because they're like, screw the radiologist, make them work harder.
Yeah.
And so they can also look for pyelo at the same time.
Okay.
Um, and then these patients will have a history of like chemotherapy, and then uh, they're on chemotherapy for like leukemia, and then they suddenly have like hyperphosphatemia, hypocalcemia, hyperkalemia, and hyper U.
Sure.
So this is uric acid.
Okay.
So hyperuricemia can cause ATN, particularly in, do you know what kind of syndrome I was talking about?
Oh, tumor lysis.
Yep, tumor lysis syndrome. Yeah, remember that all of those leukemic cells, they get lysed and they release their intracellular phosphate and potassium. Anytime we have high phosphate, what electrolyte goes down?
High phosphate.
Hmm.
What electrolyte goes down?
Hmm.
Sodium.
Calcium.
Okay.
So they get hyperphosphatemia, which causes, because remember, phosphate, it's a negative ion. So negatives and positives attract,
Yeah.
binds calcium. Phosphate binds calcium, causing hypocalcemia.
And then it's also like but in refeeding syndrome you get hypophosphatemia and
Hypophos-
hyperinsulinemia.
Yeah, you said hypophosphatemia?
Yeah.
Yep. So it's the opposite, hypophosphatemia.
Mm-hmm.
Okay. And then the last one is M.
Methanol.
Uh, so methanol affects the eyes,
Oh
um, not the kidneys. So these patients, this will be like a patient that got super wasted. Either they did cocaine or a lot of alcohol and they just passed out, passed out on the floor and they've been on the floor for 12 hours and they just fall asleep. And then they wake up with severe muscle pains,
myoglobinuria.
myoglobinuria. Excellent. So that's rhabdo that I was describing.
Yeah.
Um, they'll have really high creatinine kinase. How do we treat rhabdo?
Fluids.
Yep, IV fluids. What color will their urine be?
Red.
Yeah, red or dark.
Um,
Um, but when we look at their urine under a microscope, do we see red blood cells?
no.
No, because it is the myoglobin. They don't actually have hemoglobin in their blood. They have myoglobin. Okay, any questions?
No. Thank you. This is good.